Hello, everyone. Today, we're going to hone in on COVID-19 and the social construction of health.
The coronavirus pandemic might feel unique, although the trends and themes that have emerged as a result parallel previous events in the history of medicine and public health.
In order to formulate solutions for Dr. Marcela Nunez-Smith, we suggest first taking a step back and analyzing past administrative successes and failures.
My name is Sophia Justine.
I'm Lily Hammer.
I'm Christopher Garcia.
And I'm Mohammed Hazem, and today we'll be utilizing our extensive knowledge on medicine and health and history to support our argument that the consequences of social stratification are embedded in public health systems and trends.
So, Sophia, to start us off, why don't you tell us a little bit about what's been happening during COVID?
Sure. The coronavirus pandemic, most commonly known as COVID-19, is a SARS-CoV-2 strain. It is a novel outbreak that swept the world in 2020. The elderly and people with severe health conditions are the most affected by this respiratory pathogen. Amongst the many government responses and social practices demand to control the spread of this disease, we have seen a disturbing trend that people of lower class minority communities are the most at risk to face complications. Why is that?
The phenomenon in which certain groups are disproportionately exposed to and likely to get a disease is portrayed in examples throughout history. Specifically, the pellagra outbreak in the early 20th century targeted impoverished members of society. That is, the disease was confined to certain areas which were home to lower class workers. The factor of food availability was the prime relationship between pellagra victims. There was a direct link between economic status and food availability, which resulted in the disproportionate harm experienced by these individuals. Studies conducted by Joseph Goldberger confirmed that the improvement of economic status and food availability were the solutions to this outbreak.
Well, then what factors have driven the course of this present pandemic?
In considering factors which have driven the course of the pandemic, this historical example is relevant as health trends in the wake of COVID-19 pandemic convey a similar message. That is, socioeconomic status is linked to the likelihood of getting coronavirus and the likelihood of experiencing harsher symptoms of the disease. This historical example highlights how structural inequalities have existed within the medical realm and throughout scholarly research for a long time. These trends are not novel, as illuminated by the health statistics which expose the amplified likeliness of harsh symptoms of COVID among poor communities. Solutions to these trends can be borrowed from past findings, which entails the implementation of policy that makes resources and PPEs accessible to all people. Enactment of legislation requiring equitable access across socioeconomic lines can serve to combat this issue.
So, Hazem, we know that historical events are relevant and comparable to damage that has occurred from COVID-19, but what damage has actually occurred and how can we assess this damage?
Yeah, so in order to learn from the ongoing pandemic and mitigate harm from future pandemics, we have to first measure the impact that these events have had on citizens, and we have to do it effectively. So one way to do this is to look at excess deaths, because many patients die from complications due to COVID-19 infection, such as respiratory illness. And sometimes these deaths are not counted as COVID deaths, they're just deaths due to respiratory illness. So we need to look at the excess deaths to see how many more people are dying in a given year. Also, while this may give us a broad idea of how many people are dying due to COVID, that still doesn't give us the full picture, because many people are affected by COVID, but they don't die from it, or they have long-lasting effects. We have to incorporate methods that study the effects of social stratification caused by wealth, income, and racial disparities in order to holistically assess the damage done by pandemics. Because as we know from what Lily said, it affects people differently. In doing this, it's important to realize that the pandemic, as we've seen, has affected citizens of varying socioeconomic backgrounds in many different ways, and we can best assess the damage in a way that is cognizant of the stratification in our society, similar to how Louis-René Villermé looked into what the poor and wealthy people of society had in common and how they've been affected. Throughout his investigation of the living conditions of the working class in France, Villermé looked at the death rates across the boroughs of Paris. He looked at the poverty index, population density, and building density, and he was able to come to the conclusion that wealth and poverty are the largest factors of disparities in death and health. Villermé noticed that poor people lived in cramped, close quarters, which made them more susceptible to disease. Does this sound familiar? The notion that living in cramped spaces leads to easier spread of disease rings true in the present day, as we know. We can expand Villermé's discoveries further by delving into how individual minority groups have been disproportionately affected by the ongoing pandemic as well.
So there is data to support how Villermé's discoveries are relevant today.
Yeah, so actually, the Center for Disease Control website states that minority groups have higher infection and death rates due to lower access to healthcare, the fact that minorities work in essential settings, wealth and educational gaps, and the fact that minority populations tend to live in more crowded housing in urban settings. Data is socially constructed, though, so we have to keep in mind that we'll never be able to fully grasp the extent that different people are affected by it, but we have to do our best to get as close to that understanding as possible. It's important to understand that, again, like you won't have 100% of understanding this, but you have to get very close.
So we know that COVID and most pandemics affect people differently, but how can we actually account for this?
Yeah, so the most valuable thing we can do is ensure that every state provides data about race and ethnicity when reporting cases, hospitalizations, and deaths. This is an area where some states are currently lacking. In fact, according to an article that's published by Nancy Krieger in The Lancet, 50% of cases reported to the CDC by September of 2020 were missing data on race and ethnicity. That's 6 months after COVID-19 was declared a pandemic by the World Health Organization. So if we think about that, how can we assess the damage caused by COVID-19 when we're missing data on race and ethnicity? Furthermore, according to the National Academy for State Health Policy, as of April 19th, 2021, only 21 states reported race and ethnicity data for hospitalizations, and 7 states reported this data for testing. 6 states still don't report race and ethnicity data when accounting for deaths, which means we don't have an accurate account of how this pandemic is affecting people of color. We have to mandate the inclusion of race and ethnicity data when reporting cases, deaths, and hospitalizations across all states. This policy would not only help us assess the damage caused by COVID, it'll allow us to understand and better assess the damage caused by future pandemics as well.
So what can we even say that we've learned from COVID?
Well, we know that health is a public issue. Looking at late 19th century England, Friedrich Engels recognized how social classes were a major factor in understanding health. His investigation into social murder highlighted how contagious disease was not only a result of contact, but economic well-being. He coined the term social murder in highlighting how society is responsible for the well-being of all citizens. We see time and time again that health is a social issue, and COVID-19 has further supported this idea.
There are statistics to prove that minority lower class communities are more affected by the pandemic. The concept of allostatic load, which describes how the process in which chronic stress causes wear and tear on the body, thus increasing risks of health conditions, is relevant to consider in order to unpack COVID-19 trends. Stats from cities and states nationwide show that COVID-19 cases are more frequent and more severe in populations of color. For example, Native Americans have been hospitalized for extreme COVID-19 symptoms more than 5 times as often as white people, and the hospitalization rates among Latino and Black Americans are similarly high, according to the CDC. Structural inequalities associated with amplified infection rates among minorities exposes the need to unravel historical discrimination, which has resulted in increased likeliness of overcrowding and increased likeliness to work in low-paying jobs deemed essential.
We repeatedly recognize the importance of a government response in urgent crises. With COVID-19, rapid responses was necessary in stopping the spread of the disease. We have learned the necessary precautionary measures needed by governments in addressing public health. Likewise, we now understand that the general public is as important in ensuring the safety of everyone.
So with this in mind, what have these lessons and those of past disease episodes taught us?
Well, one aspect of COVID-19 prevention and treatment that is seemingly unique is the prevalence of asymptomatic cases. Widespread anger and scapegoating have resulted from this. For example, some people have been critical of others' lenience and comfort socializing and engaging in public activities, despite potential exposure to the virus. This trend of playing the blame game is not new in the medical realm, as exemplified by the events that unfolded in the wake of Mary Mallon's asymptomatic case of typhoid in the early 1900s. Mary Mallon was an Irish immigrant who worked as a cook, and she was the first asymptomatic case of typhoid and was forcefully detained after refusing to submit to public health authorities. The new police powers of this time, which allowed for detainment because of a positive bacteriological test, were bound to make some people resistant and hostile towards authorities. This discriminate nature of these events were seemingly associated with Mary's immigrant and female status, which lessened her authority. This is something that we see today in the world of COVID.
As referenced earlier by Lily and Hazem, people of lower economic status are more likely to be exposed to disease as they work as essential workers. The CDC has updated their site since the pandemic to highlight the health inequity prevalent in the United States. They wrote, essential workers are inherently at higher risk of being exposed to COVID-19 due to the nature of their work, and they are disproportionately representative of racial and ethnic minority groups. In industries like food, transportation, healthcare, and manufacturing that are disproportionately composed of minorities, the spread of a respiratory illness via close contact is inevitable. Like Mary Mallon, these workers cannot afford to miss work and must put themselves and others at risk and aid to return the economy to pre-COVID measures.
What policy changes can improve overall population health outcomes, both in the short term and in the long term?
I'm so glad you asked. Given the massive disproportionate impact COVID-19 has had on minority groups, it's incredibly important that any new legislation being introduced prioritizes the need of these communities. Racial and ethnic minorities in the United States have been subjected to various mechanisms of institutionalized racism, which have in turn created health disparities that have been exacerbated further by the pandemic. As my colleagues have already discussed, these mechanisms are historic in nature, and by analyzing the thoughts and practices of previous experts, we can extrapolate modern-day implications to develop more forward-thinking policy. In particular, the ideas of Rudolf Karl Virchow in his commentary over the Silesia typhus crisis hold such promise. In Virchow's investigation, he made clear that Silesian bureaucracy was severely lacking, as it offered no real protections for the poor working class. Because of the obvious hierarchical structure of Silesian life, the poor were left at the mercy of aristocrats, and in this instance, left to deal with typhus alone. Here, Virchow suggests that the only solution be radical political change, which aims to promote the advancement of marginalized communities. To apply the lessons of experts like Virchow to the modern-day COVID-19 crisis, there are some federal and state policy initiatives that need to be considered to improve both short-term and long-term health goals. One direction we suggest is addressing the increased uptake of food insecurity being faced by low-income communities across the country. The pandemic has resulted in job/wage loss, and those previously struggling to find and afford nutritious foods find themselves in an even tighter spot. In the short term, states must invest in local community organizations responsible for creating food banks and other nutritious-centered programming to ensure those already at food risk have options to find meals. On the federal level, there have been recent alterations to the Supplemental Nutrition Assistance Program, otherwise known as SNAP, which make it easier for more people to be eligible for food assistance. But these alterations only exist till the pandemic is quote unquote over, meaning every newly eligible person will be unable to make use of these benefits in the future. We believe these alterations should be made permanent, as the health implications related to food insecurity are not temporary.
In conclusion, these examples and suggestions we talked about today emphasize how critical it is to acknowledge the significance of social stratification in determining population health.
Socioeconomic status contributes to the construction of health data and trends, as exemplified by arguments made by past scholars such as Goldberger, Mierme, Ingalls, and Virchow.
Recognizing that health is a public issue highlights the importance of emphasizing approaches that integrate social influences with other determinants of disease, as portrayed by the example of Mary Mallon.
Based on these historical examples, we assert the importance that President Biden's Health Equity Task Force must focus on implementing policies to eradicate social barriers in the health system and recognize the health equity concerns highlighted prior and since the COVID-19 pandemic.
Thank you so much. Okay, I don't know how to